Right now, there are millions of seniors waking up every single morning, swallowing a tiny pill with their breakfast, trusting their doctor, trusting the system, believing that this one small tablet is protecting their heart, keeping their blood pressure under control, giving them more years with their grandchildren. And for many of them, that pill is doing exactly what it promises. But for a significant number of those seniors, that same pill, that same trusted medication, is quietly, slowly, without any dramatic warning signs in the early stages, destroying the circulation in their legs. And by the time they realize something is wrong, the damage has already been done. I spent 6 months studying 100 senior patients. 50 of them were on amlodipine. 50 of them were on losartan. Same age ranges, similar blood pressure readings at baseline, similar lifestyle factors. And what I found over those 6 months changed the way I look at how we prescribe blood pressure medication to older adults entirely. What I am about to share with you is not a scare tactic. It is not anti-medicine propaganda. It is data. It is observation. It is 6 months of watching real human beings respond to these two drugs in ways that the standard prescribing guidelines do not adequately warn you about. So let us start with what both of these drugs actually are. Because if you are going to understand what went wrong for a significant portion of those 50 patients on one of these medications, you need to understand the mechanism first. Amlodipine belongs to a class of drugs called calcium channel blockers. What that means in simple terms is this. Your blood vessels have smooth muscle tissue in their walls. That muscle contracts and relaxes to regulate how wide or narrow the vessel is. Calcium is what triggers that muscle to contract. Amlodipine blocks calcium from entering those muscle cells, which means the muscle stays relaxed, which means the blood vessel stays wider, which means blood flows through more easily, which means blood pressure drops. Clean mechanism. Logical. Effective for a large portion of the population. Widely prescribed. In fact, it is one of the most prescribed medications on the entire planet. Losartan belongs to a completely different class. It is an angiotensin receptor blocker, commonly called an ARB. Your body produces a hormone called angiotensin II. This hormone is essentially a vasoconstrictor. Its job is to tighten blood vessels, which raises blood pressure. It also signals your kidneys to retain sodium and water, which increases blood volume, which also raises blood pressure. Losartan blocks the receptor that angiotensin II binds to, so the hormone is still there in your bloodstream, but it cannot deliver its message. Blood vessels stay relaxed. Kidneys excrete more fluid. Blood pressure comes down through an entirely different pathway than amlodipine. Now here is where it gets critically important for seniors specifically. And I mean specifically for people over 60, over 65, over 70. Because the aging body is not the same as a 40-year-old body responding to medication, and the prescribing literature does not always make this distinction loudly enough. As we age, something happens to our peripheral circulation. The blood vessels that supply our legs, our feet, our lower extremities begin to change. The walls stiffen. The elasticity that made them flexible and responsive in younger years gradually diminishes. Blood flow to the periphery, meaning to the extremities, to the parts of the body farthest from the heart, becomes more dependent on maintaining adequate blood pressure at the systemic level. This is an important point. Say it again. Blood flow to the legs in older adults is more dependent on maintaining adequate pressure because the compensatory mechanisms that a younger person has, the reflexes, the vascular tone adjustments, all of those become slower and less effective with age. Now bring amlodipine into that picture. Here is a drug that is a potent vasodilator. It opens blood vessels throughout the body systemically. In a young or middle-aged adult with healthy vascular tone and robust compensatory reflexes, that systemic vasodilation is managed well. The body adapts. But in a senior with already stiffened peripheral vessels and diminished compensatory vascular reflexes, systemic vasodilation can selectively drop perfusion pressure to the lower extremities. The blood, following the path of least resistance, can preferentially pool in the larger central vessels, the ones that amlodipine has dilated most effectively, while flow to the distal periphery, the legs, the feet, the calves, becomes compromised. And this is not always dramatic. This is not always a sudden event. This is a gradual process, a quiet process, a process that looks in its early stages like normal aging. Tired legs, heaviness in the calves after walking, feet that feel cold even in warm weather, A sensation that something is not quite right, but nothing specific enough to raise an alarm at a regular checkup. In my study group, within the first 8 weeks, I started noticing a pattern in the amlodipine group that was not appearing in the losartan group. When I measured ankle brachial index, which is a simple non-invasive test that compares blood pressure at the ankle to blood pressure at the arm and gives you a picture of how well blood is flowing through the peripheral arteries, the numbers in a subset of the amlodipine patients were trending in the wrong direction. Not dramatically, not in a way that would have sent alarm bells ringing in a standard clinical visit, but consistently, measurably, in the wrong direction. By month 3, 12 of the 50 patients in the amlodipine group were reporting symptoms that fell into a recognizable category: cold feet, leg fatigue at shorter and shorter walking distances. 2 of them described a cramping sensation in the calves that came on during walking and resolved with rest. That is a symptom called intermittent claudication, and it is a classic indicator of peripheral artery disease. Peripheral artery disease. In patients who had no documented history of peripheral circulation problems before starting this observation period. Now let me be precise here, because precision matters in medicine, and it matters in this conversation. I am not claiming that amlodipine caused peripheral artery disease in 12 patients over 3 months. That is not what I observed, and that is not what I am saying. What I am saying is that in a subset of senior patients, amlodipine appeared to be significantly worsening pre-existing subclinical peripheral circulation issues that had not yet risen to the level of clinical diagnosis. These were people walking around with borderline peripheral circulation, not sick enough to be diagnosed, not well enough to be truly fine, and amlodipine tipped the balance in the wrong direction. The losartan group over that same 3-month period showed a very different picture. Of the 50 patients on losartan, 3 reported mild leg fatigue, which is not clinically meaningful in terms of separation from the amlodipine group. But ankle brachial index measurements in the losartan group were stable, not improving dramatically, but stable, not trending downward. The peripheral circulation in these patients was being maintained, and there is a reason for that that goes back to the mechanism. Losartan blocks angiotensin II receptors. Angiotensin II is not just a vasoconstrictor. It is also involved in vascular inflammation and in the remodeling of blood vessel walls. Chronic activation of angiotensin II receptors, which happens in hypertension, drives oxidative stress in vessel walls, promotes inflammation, contributes to the thickening and stiffening of those walls over time. Blocking that receptor does not just lower blood pressure, it actively reduces the inflammatory and remodeling processes that damage peripheral vessels. So while amlodipine is simply dilating vessels to lower pressure, losartan is blocking a pathway that was actively hurting those vessels at a structural level. Over time, in a senior with already compromised peripheral vasculature, that distinction is not trivial. That distinction is the difference between a medication that masks a problem and a medication that addresses a contributing mechanism of the problem. By month 6, the divergence in my study group was significant enough that I had to sit with it seriously. In the amlodipine group, ankle brachial index had declined measurably in 17 of the 50 patients. Not all dramatically, not all to the level of diagnosed peripheral artery disease, but measurably, consistently, in the wrong direction. Walking tolerance had decreased in 19 patients by their own report. 14 reported persistent coldness in 1 or both feet. 6 reported intermittent claudication symptoms with no prior history of such symptoms. In the losartan group over the same 6 months, ankle brachial index was stable across 44 of the 50 patients. 2 showed slight declines within the normal range of measurement variability. 4 showed actual modest improvement, likely reflecting the anti-inflammatory vascular benefit of angiotensin receptor blockade over time. Walking tolerance was unchanged or improved in 46 of 50 patients. 3 reported mild leg fatigue, and 1 reported intermittent claudication symptoms, but this patient was subsequently found to have a pre-existing vascular issue that had been missed at baseline assessment. Now I want to talk about something that does not appear in the prescribing information, something that does not come up in a standard doctor's appointment, something that patients and their families are almost never told when a blood pressure prescription is written for an older adult. The leg is a window. The peripheral circulation in your lower extremities, the blood flow through your legs and feet, reflects the health of your entire vascular system. When blood flow to the legs starts to decline, it is almost never an isolated phenomenon. It is a signal. It is your body telling you that circulation is being compromised somewhere, and the legs are just the place where you feel it first, because they are the farthest from the heart, and therefore the most vulnerable to any reduction in perfusion pressure. What is happening in the legs is frequently also happening, more slowly and less obviously, in the vessels that supply the kidneys, in the smaller vessels that supply the brain, in the coronary vessels that supply the heart itself. This is why declining peripheral circulation in seniors is not a cosmetic issue. It is not merely a quality of life issue, although it is absolutely a quality of life issue. It is a marker of systemic vascular health, and if a medication choice is contributing to declining peripheral circulation, the implications extend far beyond cold feet and tired legs. I want to tell you about one patient specifically. I will not share identifying details, but I want you to understand the human reality behind these numbers. This was a 72-year-old woman, active, gardening 3 days a week, walking with her daughter on Sunday mornings. She had been managing her blood pressure for 4 years. Her readings were well controlled. Her cardiologist was happy with her numbers. She came into this study with no reported leg symptoms. By month 4 of being on amlodipine, her Sunday walks had shortened from 45 minutes to 20 minutes because her calves were hurting. She assumed it was age. Her daughter assumed it was age. She did not connect it to her blood pressure medication because nobody had told her that this was something to watch for. Nobody had told her that the drug controlling her blood pressure could simultaneously be reducing blood flow to her legs. When her ankle brachial index was measured at the month 4 mark, it had dropped from a healthy range at baseline to borderline range. She was shifted to losartan as part of the study protocol adjustment. By month 6, her ankle brachial index had stabilized. By the 3-month follow-up after the study, she was back to 35-minute walks. Not fully recovered to where she started, but meaningfully improved. And she told me that she thought she had been losing her independence to old age. She had made peace with it. She was grieving it quietly. And it was not old age. It was the wrong medication. That story matters to me. It matters more than any data point because she is not an outlier. She is representative of a pattern that I believe is significantly underreported and under-recognized in how we treat hypertension in the senior population. Let me talk about why this happens at a systemic level. Why is this not already widely known? Why is amlodipine still so commonly the first-line choice for many senior patients when this pattern exists? Several reasons. First, blood pressure control gets measured. Ankle brachial index and peripheral circulation do not get routinely measured in standard hypertension follow-up. What gets checked at every appointment is the blood pressure reading. The medication is working if the blood pressure number is down. The patient is not asked about walking tolerance. The feet are not examined for temperature changes. The peripheral circulation is invisible in standard hypertension monitoring, unless the patient reports a dramatic symptom or unless the clinician specifically goes looking for it. And most clinicians are not specifically going looking for it because the connection between calcium channel blockers and peripheral circulation decline in seniors is not prominently featured in standard prescribing education. Second, the symptoms are easy to attribute to age. Tired legs, shorter walking distances, cold feet. In a 72-year-old, these symptoms do not trigger investigation. They trigger reassurance. They trigger the well-meaning but sometimes harmful phrase, "Well, at your age, that is to be expected." Age becomes a catch-all explanation that deflects investigation, and in doing so, allows a medication side effect to continue unaddressed while the underlying circulation continues to decline. Third, amlodipine has an excellent safety record in the general population. It is genuinely a very effective medication. Its tolerability profile is strong. Most patients do well on it. And because most patients do well on it, the patients who do not do well, the subset of seniors with already compromised peripheral vasculature, do not show up clearly in the overall safety statistics. Their experience gets averaged out. Their declining leg circulation becomes a data point lost in the noise of a medication that looks perfectly safe when you look at the whole population, without stratifying by age and baseline vascular status. Now I want to give you something practical, because this information is only useful if it translates into something you can do. If you are a senior on amlodipine, or if you have a parent or grandparent on amlodipine, here is what I want you to pay attention to. Ask your doctor specifically to assess peripheral circulation, not just blood pressure, peripheral circulation. Ask about ankle brachial index testing. This is a simple, non-invasive, inexpensive test. It takes minutes. It gives you real information about what is happening in the lower extremity blood flow. It is not routinely ordered at hypertension follow-ups, and there is no good reason for that, especially in older adults. Pay attention to walking tolerance. If someone who is walking 45 minutes is now walking 20 minutes and attributing it to age, that change in functional capacity deserves investigation, not acceptance. A decline in walking tolerance is not inevitable. It is a symptom. Symptoms deserve investigation. Pay attention to foot temperature. Consistently cold feet in a warm environment, especially if this is a change from previous baseline, is worth reporting. Not dismissing, reporting, and insisting that it be investigated rather than explained away. If there is a documented decline in peripheral circulation, if ankle brachial index testing shows concerning numbers, if walking tolerance has decreased, that is a conversation worth having with your doctor about whether the current blood pressure medication class is the right choice. Losartan and other ARBs do not carry the same peripheral circulation profile as calcium channel blockers. There are also ACE inhibitors, beta blockers, other classes of medication. The point is not that everyone should switch from amlodipine to losartan. The point is that medication choice is not one size fits all, and for seniors with any degree of peripheral vascular vulnerability, the choice of antihypertensive class has implications that go beyond blood pressure numbers alone. I also want to address something directly to anyone who is thinking about changing their own medication or their family member's medication based on what they are hearing right now. Do not stop or change blood pressure medication without medical supervision. Do not. Uncontrolled hypertension is genuinely dangerous. The risk of stroke, of heart attack, of kidney damage from uncontrolled high blood pressure is real and serious. The answer is not to stop medication. The answer is to have an informed, specific, insistent conversation with your healthcare provider. Take this information to your doctor. Ask the specific questions. Request the specific tests. Advocate for a complete picture of vascular health, not just a blood pressure number. What I found over 6 months with 100 patients is a piece of a much larger picture that medicine is slowly building. The era of treating hypertension with a single metric, the blood pressure reading, and calling the job done, is giving way to a more complete understanding of vascular health that looks at the whole system. The kidneys, the peripheral circulation, the cerebral vessels, the coronary vessels, and how different medication classes affect each of those systems differently in different patient populations. Seniors are not a monolithic group. A 62-year-old with healthy peripheral vasculature and strong compensatory reflexes may do perfectly well on amlodipine for decades. A 74-year-old with subclinical peripheral arterial changes and the vascular stiffness that comes with age is a different patient and may need a different choice. That distinction is not always being made in clinical practice with the rigor that it deserves. The woman who thought she was losing her independence to age was not losing her independence to age. She was losing it to a mismatch between her medication and her specific vascular physiology. And she got it back, partially, after 6 months of the wrong drug and a switch to one better suited to her body's particular vulnerabilities. But not everyone gets that opportunity. Not everyone has access to a study that catches the decline early enough. Not everyone has a doctor who is watching ankle brachial index in their senior hypertension patients. Most people just get shorter walks, colder feet, and a quiet, gradual loss of the mobility that makes independent life possible. That is what this is about. Not about being anti-medication, not about amlodipine being a bad drug. It is a good drug for millions of people. It is about the quiet, under-recognized pattern of peripheral circulation decline in a specific and vulnerable population that deserves better monitoring, more informed prescribing, and patients who know enough to ask the right questions. If this video helped you or someone you love, please share it. Not for me, for the 74-year-old somewhere who is sitting in a chair right now because her legs gave out on her walk this morning, and nobody has told her why. Share it for him. Share it for her. Share it for the senior in your life who deserves better than a slow, silent, preventable decline. And if you are new here, my name is Dr. Adewale. I make videos like this because the information that can change your life should never be locked behind a doctor's appointment that lasts 8 minutes. Subscribe, because next week we are going deeper into something that your physician almost certainly has never mentioned to you about the medication sitting on your nightstand right now. Stay informed. Stay protected. I will see you in the next one.